So with that said, I'm going to go ahead and discuss some personal cases of mine and try to highlight areas of importance. And then maybe in the question and answer section and at the end, we can discuss these a little bit more in depth. So this is a 41-year-old African-American male who came to me from an outside hospital. He has history of factor V, had previous DVT, previous pulmonary embolism. The patient had a IVC filter placed several years before this and came in with severe lower extremity edema and back pain. They actually had an ultrasound done at the outside hospital, which showed no DVT, but ultimately got a CT scan because of the low back pain, which showed IVC filter thrombosis. So since I knew that by way of the venous ultrasound that the common femoral veins were open, when the patient showed up, I was able to, unlike the most cases where I go popliteal, I access the common femoral veins bilaterally. So if you look at the left and right, you see bilateral iliac venograms, and what you can see is both on the right and left, you have complete occlusion of the common iliac vein extending all the way into the filter with complete flow, complete lack of flow. There's a pretty extensive collaterals coming off mainly from the left side. So this patient had really no flow coming out of the iliac IVC system. So not surprisingly, they had severe edema and severe pain with this type of presentation. So after doing this, I always do a selective inferior vena cava venogram, and this shows an unbelievably extensive thrombus extending across the whole IVC, infrarenally, even extending in the suprarenal IVC. Very, very dangerous. Very, very scary looking venogram. So once I saw this, I was thinking in my mind, how do I approach it? So with that said, I'm going to throw that out to all of you now and poll everybody to see how they would approach this particular patient. So generally speaking, after seeing this, how would one approach this patient? With anticoagulation alone, angiojet, with EKOS, acoustic pulse thrombolysis, or angiovac? So again, I'll give about 10-15 seconds for people to answer. Okay, we'll go ahead and close the poll and look at the results. So not surprisingly, this is a webinar I'm highlighting the importance of EKOS, and the vast majority of people selected EKOS, and that actually completely correlated with how I approach this patient, and we'll talk about that in the upcoming slides. So continuing, as we just discussed, I placed 2 EKOS catheters coming from both common femoral veins, as you can see, going from essentially the sheath all the way into the suprarenal IVC distribution. Once we did this, we dripped the patient overnight and brought the patient back the next day. And amazingly, this is one of the first cases I did a few years ago using EKOS in this distribution, and I was amazed to see that you almost have, essentially you have complete clot lysis and really no residual clot in the bilateral common iliac veins, which were completely occluded in the previous pre-treatment venogram. In addition to this, if you look at the IVC venogram, which we showed, which was absolutely full with clot, after 1 day of EKOS thrombolysis, you have complete resolution of the IVC thrombus. This is an unbelievable result. The patient's legs decompressed within 24 to 48 hours, and he's done fine since. So the second case is a 60-year-old African-American female. She presented with one history of severe pain in the left lower extremity, acute onset, had shortness of breath as well. This was preceded by a long train ride, diagnosed in the ER with a bilateral submass of PE. Therefore, EKOS was used from a PE standpoint. After that was done, a venous ultrasound was done, which basically showed extensive DVT from the left common femoral vein all the way down. So since the patient had proximal DVT, had low risk of bleeding, I offered that patient DVT intervention. So we placed her in a prone position. We accessed the popliteal vein using ultrasound-guided access. As you can see on the left side, you have essentially complete occlusion of the femoral vein due to extensive thrombus. And then if you look at the right side, you see this is a selective iliac venogram, and it looks widely open. There's no clot, and there's no obvious residual stenosis or compression syndrome that I see. So this patient I thought was a good candidate for potentially angiojet, because the clot burden was not enormous and it was very acute presentation. So we've used the angiojet Zalante, which is the 8 French catheter that's relatively new for them. No IVC filter was placed for the reasons that we mentioned before. We used angiojet thrombectomy followed by adjunctive balloon angioplasty. So as I mentioned before, unlike the peripheral arterial distribution, we use much larger balloons. So we use an 8.0 by 200 balloon for balloon maceration post-angiojet, followed by a 10.0 by 80 balloon. We would never use a 10.0 balloon in the superficial femoral artery except for under maybe very strange, rare circumstances. but this is almost always done in the DVT world. After that, we have restoration of flow in the femoral vein and common femoral vein. And then after that, we look at the intravascular ultrasound, as I mentioned. And once you look at this, and this is IVUS catheter is actually in the inferior vena cava, and it's not playing 100% like I like, but this is the left common iliac vein being fully compressed at this level by the artery, which is at 12 o'clock. And so if you see this type of thing, and then as we pull back, we're in the left external iliac vein, it opens up again. So this right there, that image that you just saw, is the artery actually compressing the left common iliac vein. Because the left, generally speaking, the left common iliac vein should be much larger than the artery. So this patient indeed had May-Thurner syndrome, and that was likely the trigger of this. So as I mentioned earlier in the tips and tricks, this patient, the IVUS didn't clearly delineate the bifurcation, which it usually does. So I went up and over with an IMA catheter. I clearly delineated by way of the vertebral body and intravertebral space where the landmark for the bifurcation is. Then on the right side, I went ahead and deployed a wall stent, and then very aggressive post-dilation with large balloons, 16 or 18 millimeter balloons. These are things we never use again in the arterial bed. So this is a stent image. This is a venogram post-stenting, and this is the intravascular ultrasound showing excellent stent apposition. So I was very happy with this. The patient did well, and the leg decompressed. The third case is a 58-year-old gentleman, 2-day history of left lower extremity pain, edema, had a motor vehicle accident a few months ago, was bed rested for this. So I had a venous ultrasound, which of course showed extensive DVT, not surprisingly, with proximal involvement because it did involve the common femoral vein. So we placed the patient in a prone position. We had ultrasound guided access, and then you can see here this is the popliteal femoral vein venogram. You can see that it's the popliteal and femoral vein have extensive thrombus on this image all the way throughout the femoral vein proximally. So in addition to this, we injected higher up, and you see you actually have complete flow cessation right at the common femoral vein level. After this, we actually did, as I do with all cases, inferior vena cava venogram. And once I did this, this is one of those oh my God moments. Unlike what I stated in the previous cases, where I don't recommend putting an IVC filter, this is where I recommend putting an IVC filter. This is a massive thrombus extending from the iliac vein all the way to almost the suprarenal IVC. And if you look at the image, you can actually see the thrombus is actually mobile. It's moving back and forth. It doesn't play as well in this video here. But once I saw this, I stopped the procedure where I was. I flipped the patient supine, and I placed I accessed the contralateral groin, and I placed a temporary IVC filter just above that massive clot burden. And so this is where cases like this, in my mind, mandate an IVC filter, temporary IVC filter placement. So this just shows you that the EKOS catheters were placed bilaterally, the filter was placed above the clot, and the patient was dripped overnight. After the patient was dripped overnight, we brought them back the next day. We do venogram. You can see the IVC now is fully patent. One thing that is very, very important and stood out to me when you're looking at this venogram is now there's a clot actually embedded within the filter. So this highlights once again why an IVC filter is important in cases like this. This filter caught some residual clot that embolized and prevented it from going to the lung. So I was so happy that I placed this filter in this patient. After EKOS, you can see you have restoration of flow in the common femoral, external iliac, and femoral vein, which was completely occluded pre-treatment. And so on day 2, which I was just showing pictures of, the patient also had adjunctive care. As I mentioned, one of the issues with EKOS alone is it's a 50-centimeter catheter is their longest catheter. So if you have a case like this requiring catheter placement from the inferior vena cava all the way down, it'll only reach a lot of times to the mid-femoral vein. So I typically do angiojet within the popliteal sheath all the way up, or even adjunctively if needed higher up, followed by balloon angioplasty, intravascular ultrasound, wall stent placement, as I showed you before, and the case is complete at that point. So this is just the iliac venogram post-stenting showing complete restoration of otherwise previously occluded left iliac vein. And again, the patient's symptoms very quickly decompressed, and he did much better. So a little bit about chronic DVTs. Dr. Garcia is one of the main leading physicians who's really looked into chronic DVT treatment in terms of interventional. And who are the candidates? Generally speaking, Unlike acute DVTs with proximal involvement, where as long as you meet the criteria we discussed, we typically offer it. Chronic DVTs, we really only offer it to patients who have real severe post-thrombotic syndrome, patients who, generally speaking, have debilitating symptoms. Dr. Garcia authored a study looking at about 100 patients with chronic DVT. And if they were able to cross, which they did almost 98% of cases, they got complete restoration of flow in about 50% of cases. So it's not definitely nowhere near what you would see with acute DVTs, but if you're able to cross and do appropriate treatment, the early and long-term improvement for venous patency is seen in follow-up, and patients do better. So again, this is really reserved for those patients who have really bad symptoms. So which modality should one use with chronic DVTs? Well, unlike acute DVTs where there's multiple options, I would say with chronic DVTs, EKOS is the only thing I even consider, because angiojet and trellis, which is really no longer used, are very ineffective at getting angiographic clearance and decreasing pain. So generally speaking, this table here shows why that is, and shows why EKOS is really the best treatment for chronic DVT. So by way of example, this is a 50-year-old lady who came to me with chronic pain in her left groin and thigh pain for many years. So I did an ultrasound, and I did actually a CT venogram and showed that her left iliac vein was completely occluded. So we initially approached her from a popliteal vein, and right at the common femoral vein, she had like a Medusa-like collateral. So anytime I tried to wire with any wire, glide wire, or crossing CTO wire, it would go up one of the collaterals, and it was almost impossible. There was no clear stump. So I actually brought the patient back and went from her neck, right IJ approach. And after doing that, after careful finding the stump at the distal IVC, I was able to wire down all the way into the common femoral vein, and then confirmed with injection through the crossing catheter, and then I was confirmed that I was in the common femoral vein. I EKOSed the patient overnight, did angioplasty, intravascular ultrasound, placed the self-expanding stent after doing that on day 2, and completely basically recreated back the otherwise 100% chronically total occluded iliac vein all the way to the distal IVC. And this patient's done very well since then. Her left groin and thigh pain completely resolved within a few days of doing this. So just another example, once again highlighting the importance of May-Thurner syndrome. This is a 60-year-old patient who came in with left lower extremity pain, had a venogram, CT venogram, which showed severe stenosis. We brought her in, did a venogram through the groin, and you can see extensive collaterals right at that left distal common iliac vein with that web-like appearance, which is classic for May-Thurner syndrome. We did intravascular ultrasound. You could see the artery, which is at like 1 o'clock here, compressing the vein. So this is the IVUS image you see when you see compression syndromes, and you should put that in your mind. After doing that, of course, we went ahead and proceeded with balloon angioplasty, followed by placement of a wall stent using IVUS for guidance of the size of the stent, and the patient did very well. So in conclusion, deep vein thrombosis treatment substantially reduces the risk of post-thrombotic syndrome and provides immediate relief in symptoms. Intervention should be offered to patients who have proximal or extensive DVT as long as they have no contraindications, as we discussed before. There's multiple modalities available. You should individualize that to the patient and to the local expertise. Intravascular ultrasound is an absolute must for any person who is going to embark on DVT intervention, both to diagnose venous compression and also assist in adjunctive therapy like stenting.